Good evening, ladies and gentlemen. I think we are ready to start, and thank you for joining us on this Wednesday evening, and welcome to the fourth and the last session of the Genetics 360 educational webinar series hosted by MUTYH Laboratories. We request all attendees to keep their microphones and cameras off. Should you have any questions, please make use of the chat section where you could either publicly or privately send a question to a presenter. Please also remember that we will run poll questions after both presentations, and the answers for these will also be provided. I will now hand over to Sarah Walters, a genetic counsellor at MUTYH, who will introduce our topic and our speaker for this session. Thank you, Sarah.
Good evening, everyone. So we come to our last lecture, and we have moved through pre-birth, we've moved through childhood, we've moved into adulthood, and now we're moving on to later adulthood and some potential genetic conditions that may be picked up. And it gives me great pleasure to introduce my work colleague, Julie Milan. She was one of the first registered genetic counsellors in the country, and she has a vast amount of experience at counselling particularly around breast and ovarian cancer, and she's going to lead us through a couple of the common cancer syndromes. So thank you, Julie, and welcome.
Thank you so much, Sarah, and thanks everyone for tuning in. And there we go, we will start. So the topic of my talk tonight is adult-onset genetic diseases. So we do know that adult-onset genetic conditions are genetic disorders that manifest themselves after childhood and adolescence. These disorders are often involve genetic factors interacting with environmental factors over a period of time. And these genetic disorders require genetic evaluation for diagnosis and management. Adult-onset genetic conditions may include neurogenetic disorders such as Charcot-Marie-Tooth disease, Huntington's disease, myotonic dystrophy, and spinocerebellar ataxia. Hereditary heart disease, including hypertrophic cardiomyopathy and hereditary long QT syndrome. Looking at metabolic diseases, we've got hemochromatosis or iron overload, as well as porphyria, and then of course our cancers. And tonight we will be talking about cancers. My part of the talk tonight will be about cancers, and particularly looking at breast and colorectal cancers. So this slide just wanted to show you some examples of single gene disorders that we find in adults. And you can see there's a whole range of them, and it covers fields in neurology, nephrology, hematology, pulmonary disorders, cardiac disorders, some infectious diseases, metabolic disorders, gastroenterology, oncology, musculoskeletal disorders, and then also of the skin, dermatology. So with that introduction, I want to jump straight into the topic that I'm really going to look at tonight, which is hereditary cancer. So we know that cancer is caused by pathogenic variants, also known as mutations previously, in genes which control cell growth and division. And these mutations can be either inherited or acquired. And usually it leads to oncogenes inactivation and or tumor suppressor gene inactivation. Or let me rather say oncogene activation and tumor suppressor gene inactivation. We know that the majority of cancers that we see occur in the absence of a significant family history and are not inherited. So in these cases of cancer, we see that the pathogenic variants are found only in the tumor, and we call that somatic changes. And these are changes that you are not born with, but you acquire after birth over your lifetime. We also find cancers that can be caused by a combination of environmental or lifestyle and genetic factors. And this is what we term familial cancer. So we'll see a family pedigree with a lot of cancers in the pedigree and doing genetic testing, and we won't really find a genetic answer. And these we will then refer to as familial cancer. And then in 5 to 10% of all cases, we know that cancer can be due to a hereditary cause. And this is caused by errors or faults in genes which are supposed to protect our bodies from developing cancer. So if we look at the pie chart that I have on the slide, you will see sporadic cancers, as we call them, make up the majority. 70 to 80% of all the cancers we see are what we call the sporadic cancers. Then about 15 to 20% falls in the group of familial cancers, and then the 5 to 10% are the hereditary cancers. And these really are the cancers that we as genetic counselors are very interested in. Because part of our job is to try and see, can we find the hereditary cause for the cancer in this family? As this will then impact on not only the person sitting in front of me, but then also a whole family, because we will be able to give them quite good risk estimations, and then they will also be able to look at different management options with regards to their cancer risk. So if we talk about hereditary cancers, what do we as doctors, as counselors need to look at? What are some clues that raises a suspicion of a hereditary cancer? And here I'm just listing 5 things that we can see within these families where we are looking for a hereditary cancer. First of all, there's the age of diagnosis. And when we see cancer happening at a young age, very much younger than what we are used to, the average person presents with this specific type of cancer, it raises a flag with us, because what is the reason for developing a cancer at such a young age? Then, of course, as counselors, we draw a thorough family pedigree. And looking at a family pedigree, what we will see is multiple generations affected with cancers. We also look at specific patterns of cancers occurring in a family. For example, when we see breast and ovarian cancer within a family, or where we see colorectal and endometrial cancer in the females in the same family, then we know we might be looking at a hereditary cancer. Then more than one primary cancer within the same person, and then also certain cancer pathology types, such as high-grade serous ovarian cancer, when we're talking about hereditary breast ovarian cancer syndrome, and endometrial cancers, talking about Lynch syndrome. So let's have a look closer at breast cancer. We know that the average woman out there has a risk of about 13% to develop breast cancer sometime during her lifetime. But we also know that the majority of these women who develop breast cancer do so without any family history. And it's quite interesting when we do genetic counseling, sitting with our patients, they are quite surprised when we mention these figures to them, because they only know their family who is riddled with breast cancer. So we know 5 to 10% of all breast cancers can be associated with germline BRCA or BRCA pathogenic variants. And we know that specific inherited pathogenic variants in BRCA1 and 2 increases the risk of female breast and ovarian cancers. And BRCA1 and families with BRCA1 and 2 mutations, we usually say have hereditary breast ovarian cancer syndrome. And in recent years, testing for cancer susceptibility genes has become a part of clinical practice. So what are the criteria when a woman is sitting in front of me? What do I look at? What are the questions asked to suspect that there is inherited cancer in the family? And here I've listed some of the ones that we see most often. First of all, a personal history of breast cancer before 45 years of age. If there's breast and ovarian cancer in the family. If we see breast cancer in different generations. A male breast cancer in the family also makes us very concerned, specifically about a BRCA2 mutation. If a woman presents with breast cancer in both breasts, bilateral breast cancer. In the last couple of years, it's become more clear that looking at triple negative breast cancer under the age of 60 years may also be an important indicator of a BRCA1 mutation. Then a personal history of ovarian cancer, because ovarian cancer is such a rare cancer that we see in the general population of women, we are quite concerned if there are women with ovarian cancer in a family. Then if a woman has a known relative or a relative with a known BRCA mutation, and then also if the person sitting in front of you has a personal history of breast cancer and is of Ashkenazi Jewish descent, then we are also concerned. So over the 4 weeks, we've heard of and learned a lot about genes and their inheritance patterns. So just to refresh you, we know that the breast cancer or the cancer susceptibility genes are inherited in an autosomal dominant inheritance pattern. And what this means is if a parent has a pathogenic variant in one of these susceptibility genes, there is a 50% chance of passing it down to his or her children. We know that children who inherit this pathogenic variant in turn have a risk to pass this on to their children. And we know that other families, such as siblings, uncles, and aunts, also have a chance to have inherited this gene fault or this pathogenic variant. We also know that even if we talk about breast cancer, that the pathogenic variant can be passed on either from the paternal or the maternal side of the family. So quickly refreshing what genes are and what they look like. So we know we've got all our cells with the nucleus, and within the nucleus, we've got our chromosomes. And we know that genes are the short segments of DNA found in the chromosomes. So our genes are packed within our chromosomes. Genes contain the instructions for building proteins, and the proteins control the structure and function of all the cells that make up our body. So we can think of our genes as though they are the instruction manuals of life, and they also are the manual for cell growth and every function that happens in our body. And a gene abnormality or a pathogenic variant is like having a typing error in this manual. And this then gives the wrong set of instructions, which leads to faulty cell growth or function when we are talking specifically about cancer. So when we talk about cancer and cancer susceptibility genes, we always talk or mostly talk about tumor suppressor genes. So most breast cancer predisposing genes are tumor suppressor genes that are involved in DNA damage repair pathways and cell cycle control. And we all are aware of BRCA1 and BRCA2, but we know there are more than just BRCA1 and 2 other tumor suppressor genes that can also increase the risk for breast and ovarian cancers. And the ones that we think of mostly when we look at a family where there seems to be a hereditary breast cancer are BRCA1 and 2, the TP53, P10, STK11, CDH1, the CHEK2, ATM, PALB2, and the BRIP1 gene. And mutations in any of these genes causes a loss of function and cause genomic instability and uncontrolled cell cycle. This in turn then leads to the uncontrolled growth of tumor cells. Everyone has got 2 copies of each of these genes, and 1 copy is inherited from each parent. It's quite interesting. Often you hear our patients talking, saying, do I have the BRCA gene? We all have got 2 copies of the BRCA genes. Some of us just has got a pathogenic variant on those genes. So a person who inherits a pathogenic variant from one parent are then at an increased risk of several cancers, and most notably, if we talk about BRCA1 and 2, breast and ovarian cancer. The picture of the racing car that I've got here is just a way in which we explain to our patients the role of tumor suppressor genes in our bodies. Because very often we remember pictures much better than we do just the words that the counsellor is talking to me. So we always say cell division is like a racing car that's racing forward. And if I want to prevent an accident from happening to my racing car, I need brakes. And the brakes for these cell division are our tumor suppressor genes. So if the tumor suppressor gene is inactivated, it means my racing car is driving around with no brakes, and that then increases the risk for breast or ovarian cancer. Another way to look at these cancers and the way in which, or the hypothesis through which cancer susceptibility works is a hypothesis known as Knudsons 2-hit hypothesis. And tumor suppressor genes generally follow this 2-hit hypothesis. This hypothesis states that both alleles that code for a particular protein must be affected before an effect is manifested. So if only one allele for the gene is damaged, the other one can still produce enough of the correct protein to retain the appropriate function. So in this picture, what you can see at the bottom is the general woman out there who hasn't got a family history of cancer, who's got 2 normal copies of, let's say, in this case, the BRCA1 gene. And through her lifetime, for both copies of those genes, of that gene not to function, she will basically need 2 hits from the outside. And this is where our environment comes into play before both copies of the gene is knocked out and might be that last step necessary for the cancer to happen. The top part of this picture shows you a person who inherited what we call a germline mutation. So this person inherited a pathogenic variant in this case, let's say again, the BRCA1 gene. So this person is already born with that first hit that has already happened. And then through life, only 1 more hit is needed to knock out a second copy of the gene. And this then also explains to us why we often see that in inherited cancers, that people present with cancer, in the case of breast cancer, ovarian cancer, at a younger age than what we would generally expect. So in this table, I just want to summarize the other genes that I mentioned on a previous slide that are all breast cancer susceptibility genes and how they may impact in a person's life. So the ATM gene, we know 2 pathogenic variants in this gene causes the disease ataxia-telangiectasia. But inheriting 1 pathogenic variant in this gene has been linked to a higher rate of breast cancer in some families. The TP53 gene is associated with a disease known as Lee-Fraumeni syndrome, and a pathogenic variant in this gene leads to an increased risk for breast cancer, as well as some other cancers such as leukemia, brain tumors, and sarcomas. And this is a rare cause for breast cancer. The CHEK2 gene also increases breast cancer risk. The PTEN gene causes Cowden syndrome, a rare disorder that puts people at a higher risk for both cancer and benign tumors in the breast, as well as growth in the digestive tract, thyroid, uterus, and ovaries. The CDH1 gene is associated with hereditary diffuse gastric cancer, and a syndrome in which people develop a rare type of stomach cancer, as well as an increased risk for invasive lobular breast cancer. The STK11 gene increases or leads to what is known as Peutz-Jeghers syndrome. And this is a disease that is, we can see pigmented spots on the lips and the mouth, polyps in the urinary and digestive tract, and a higher risk of many types of cancers, including breast cancer. And I've got a slide further on that will just refer back to Peutz-Jeghers syndrome. And then lastly, the PALB2 gene, which makes a protein that interacts with the protein made by the BRCA2 gene, and therefore also leads to a higher risk of breast cancer. So this graph just wants to put into perspective what the risks associated are associated with a BRCA1 or BRCA2 pathogenic variant in a person. So the blue in the graph shows us the general population's risk to be diagnosed with the specific cancers, and the red then to what levels that risk increases when one has a pathogenic variant. So as you can see, breast cancer risk around about 12-13%. With a BRCA1 or 2 mutation, it goes up to between 60 to 80%. Ovarian cancer, very rare. With a BRCA1 or 2 mutation, it goes up to between 30 to 50%. For the men with a BRCA mutation, the risk for prostate cancer also increases. This goes to around about 40%, and then a slight increase for pancreatic and male breast cancer. And male breast cancer we see most often with a BRCA2 mutation, and that risk goes to around about 8 to 10%. So when we do genetic testing, there are different answers that we can get. So patients always come to us and they expect we're going to get a definite yes or no answer. And unfortunately, with genetic testing, that is not always the case. So one of the things that we do before, when we do pre-test genetic counseling, is explain all the types of answers we can get if we do sequencing of, for example, the BRCA1 and BRCA2 genes. So first of all, a positive result. This means a person has inherited a known pathogenic or likely pathogenic variant in a cancer susceptibility gene and has an increased risk of developing certain cancers. And this is a result that we know how to interpret, and usually we've got management guidelines that we can discuss with the patient, and we can send the patient back to a doctor to go over and discuss future treatment or management and screening options. A negative result means that no pathogenic variant was found in the gene sequence. So this can also be one of two. The first option is if a close blood relative of the tested person is known to carry a pathogenic variant, this result is called a true negative, and the patient has a risk of cancer that is similar to that of someone in the general population. So a true negative result we can get if we know what the specific pathogenic variant within that family is. But if the tested person has no personal history of cancer and their family isn't known to carry a harmful variant, then a negative test result can be considered as uninformative. The reason being, it might be that one of the genes we looked at or the gene we tested is the gene responsible for the cancer in the family, and this patient did not inherit it, who's not been diagnosed with cancer. Or it may be what is going on in this family is a different gene to what we have been testing. And we won't know unless other family members are tested and a mutation is found. And then we find the answer that we don't like to get and is often causes some anxiousness amongst the patients is when we find a variant of uncertain significance. A variant of uncertain significance are sequence variants that currently have insufficient evidence to know whether they cause disease or not. So some of these variants of uncertain significance may be reclassified as researchers learn more about these variants linked to cancer. And this is quite difficult to explain to patients because what we tell them is we've seen a variant in your gene, but at this time we are uncertain what this variant means. And for some people that makes them quite anxious because all they think of, there's something wrong and I might be at a higher risk. We also need to make sure that patients as well as the doctors understand we cannot make any management decisions when there's just a variant of uncertain significance. We also know that the majority of these variants of uncertain significance will be reclassified as benign, negative results, but there are a few that will become in future reclassified as pathogenic variants. So on the next 3 slides, I just want to share 3 family pedigrees with you, just to show you that the testing that we do can be so good in getting answers, but sometimes we, as counselors, also get quite frustrated if we don't get the answers that we expect. So this first family is of a lady who came to see me, 40 years of age, the index patient, and recently diagnosed with breast cancer. When we took the family history, the following was seen. As you can see on the pedigree, her father was diagnosed with prostate cancer at the age of 64. He is still alive and well at 76. Mom is alive. She's 72 years old. The history given with regard to mom was that she had a total hysterectomy in her early 40s, and she also had prophylactic bilateral mastectomy at the age of 50 years because of her family history. The patient had a maternal aunt and cousin who were both diagnosed with breast cancers at a very young age, and the maternal aunt actually had bilateral breast cancer. Grandmother grew old. She passed away at the age of 83, but she also had a sister who was diagnosed with breast cancer. And then grandfather was diagnosed with prostate cancer in his 60s, and just to top it, he also was diagnosed with breast cancer. So this family would be very suggestive of a BRCA mutation, a BRCA2 mutation, probably if we take it from father's side. From mom's side, there's also, or not from her grandfather's side, on her mom's side of the family. And we did genetic testing, and we did a panel of 20 genes, and the result came back as negative. So in this family, at this time, we cannot give the genetic reason for all the cancers in the family. And our job is to ensure that even though we don't have a genetic answer, that people in this family stay aware of their cancer risk. Because in this family, there's definitely an increased risk to be diagnosed with cancer. The second family pedigree that I want to show you is of what we call a typical Afrikaner mutation, as we call it. So this is the BRCA2 7934 deletion G pathogenic variant that was detected in this family. And what we see here is very typical of our BRCA2 families. So our index patient came to us. She was diagnosed with breast cancer at the age of 37, currently 44 years. She came to the clinic with one of her twin sisters, and they came because at the time when I started seeing them, their older sister was quite sick again with breast cancer. And they were now concerned about what was the reason for this. You can see if we look at the family pedigree, dad was diagnosed with prostate cancer. There's a maternal aunt who was diagnosed with ovarian cancer and one with breast cancer. If we go up one more generation, we've got a grandmother with breast and pancreatic cancer. We've got a lung cancer, prostate, and another pancreatic cancer. And in this case, we could give a good result to this family because while we know what is going on in this family, and we can now go and also test people who are at risk of inheriting the same pathogenic variant, but has not been diagnosed with breast cancer or any other cancer, and give them valuable information with regards to their management option. So since I've started seeing the family, I have seen two other parts. I've seen an aunt, I've seen a cousin as well, who will also now go for genetic testing, and the two twin sisters we have also sent away for testing. What is very important, and what I forgot to mention previously, is it's important to remember if we inherit, a person who inherits a BRCA mutation, it does not mean they have got cancer. It means they've got that increased risk to be diagnosed with cancer. And then the third family is one where, looking at it as well, we can see the index patient with breast cancer. She had a brother who was diagnosed with prostate cancer at the age of 52. Her mother was diagnosed with breast cancer at 37. There was an uncle with liver cancer, and then grandfather on mom's side of the family with stomach cancer. On that side of the family, there were also some cancers. This sample was also sent away, and we did testing. We started off with a panel of 20 genes. We increased it to include a panel of 84 genes. And all we found were variants of uncertain significance. And in this case, it was suggested that we can send in blood samples of other family members to go and try and find out if there's a way to reclassify these variants. But at this point of time, there are no other family members alive who will be able to give us the relevant information. It would have been great if we could have tested mom and perhaps brother, but they unfortunately have passed away. So just a summary of the tests that are currently offered with regards to breast cancer. The first one, familial mutation testing, is when we test for a specific known mutation in the family, where we will get either a positive or a true negative answer. We can do founders mutation testing, where we offer the 8 most common mutations found in the Ashkenazi Jewish and Afrikaner population, and here we only exclude then those 8 specific mutations. We can also offer BRCA1 and 2 sequencing, as well as a panel of 9 genes, which we can do locally. And then also we can send samples overseas to do bigger panels of genes. And always remembering, when we do sequencing of the genes, we can get positive, negative, or variants of uncertain significance as answers. So moving from breast cancer over to colorectal cancer, the general population's risk for colon cancer is about 1 in 18, or 5.5%. And we know, similar to breast cancer, about 5 to 10% of colon cancers are hereditary. So colorectal cancer is a malignancy of the large intestine and or rectum, the colon and rectum, and hereditary colon cancer syndromes are generally divided into 2 types, Lynch syndrome and polyposis syndromes. Lynch syndrome is also called hereditary non-polyposis colon cancer and is caused by pathogenic variants in the MLH1, MSH2, MSH6, PMS2, and EpCAM genes. And this condition is the most common inherited cause of colorectal cancer and accounts for about 3% of all these diagnoses. The polyposis syndromes are characterized by the development of numerous precancerous polyps, which may over time become malignant. So looking at familial adenomatous polyposis, or FAP, and Gardner syndrome are caused by inherited changes in the gene that we call the APC gene, a tumor suppressor gene. And pathogenic variants in the APC gene causes hundreds of polyps to form in the colon. And over time, cancer will nearly always develop in one or more of these polyps. Lynch syndrome, on the opposite side, is caused by pathogenic variants in genes that normally help a cell repair damaged DNA. And we listed them on the previous slide. So Lynch syndrome is a disease that increases the risk of many types of cancers, particularly cancers of the colon and rectum, which are collectively referred to as colorectal cancer. But people with Lynch syndrome also have an increased risk of cancers of the stomach, small intestine, liver, gallbladder ducts, urinary tract, brain, and skin. Additionally, women with this disorder have a high risk of cancer of the ovaries and the endometrium as well. So overall, that the risk for women with Lynch syndrome is higher than that for men, because they have that also the extra ovarian and the endometrial cancer risk as well. And the picture there will just show you, if we talk about the different types of cancer, endometrial cancer, we'll see 43% of those associated with Lynch syndrome will be the MLH1 gene. And you can see all of these differ from each other. So there's well-known criteria that can be used for the diagnosis of Lynch syndrome. And the two most well-known are the Amsterdam criteria and the Bethesda criteria. And you can see from there, there's a whole list of things, a whole tick box that one can run through, from looking at 3 or more relatives with colorectal cancer or with HNPCC-associated cancer. If there's endometrial cancer going with the colorectal cancer, small bowel adenocarcinoma, ureter or renal pelvis cancer, if there are 2 successive generations that's affected. So doctors can use these 2 criteria to go and have a look if their patient's sitting in front of them, or should go for possible Lynch syndrome testing. Do they fit the criteria for these tests? Then just looking at Peutz-Jeghers syndrome, which is caused, as we said, by pathogenic variants in the STK11 gene, which causes an increased risk for developing hematomatous polyps in the digestive tract, as well as cancers of the breast, colon and rectum, pancreas, stomach, testicles, ovaries, lungs, cervix, and other types. Without appropriate medical surveillance, the lifetime risk of cancer may be as high as 93%. And children can develop pigmented areas on the skin and in the mouth called mucocutaneous hyperpigmentation, dark blue or dark brown freckling, especially around the mouth and on the lips, fingers, and toes. And there's just a picture showing you the lips with the freckling. And individuals with at least 2 of the following characteristics may be considered to have PJS, at least 2 PJS type hematomatosis polyps in the small intestine, characteristic freckling of the mouth, lips, fingers, or toes, and at least 1 relative diagnosed with PJS. Then the last cancer that I just quickly want to touch on is the MUTYH-associated polyposis. And this is an autosomal recessive polyposis syndrome. It's caused by mutations in the MUTYH gene, which is involved in how the cell proofreads or checks the DNA and fixes errors when the cell divides. And genetic testing is recommended for individuals with more than 20 polyps and may be considered in individuals with 10 to 20 polyps with other personal and or family features. This syndrome have nearly 100% risk of developing colorectal cancer by the age of 5, and 5% risk of developing duodenal cancer, and a modestly increased risk for later onset malignancies of the ovary and the bladder. So in conclusion, just to summarize, the role of genetic testing in hereditary cancer is as follows. For those with cancer, is knowing if someone has a genetic predisposition predisposition to cancer can help with important management and treatment decisions that could save their lives. For those without cancer, we can offer risk management recommendations that can help them manage or lower their risk for developing cancer in the future. And these can include surveillance options or risk-reducing surgeries. So at the end of the day, having genetic testing available for these hereditary cancer help us to personalize the management of each patient. As within a family, we will be able to know who are those at higher risk and who are those that won't need that extra screening or management options. I thank you for your time. So with this, I will now hand over to Sarah Walters, and she will talk to you about Huntington's disease and Alzheimer. Thank you.
Thank you, everyone. So I'm going to take us on a quick whirlwind trip through Huntington's career and Alzheimer's, particularly because these are often conditions that we see in much older people, developing at a much later age. Huntington's disease, I know I've spoken to you before in one of my previous presentations. So it's an inherited disorder which is caused by a faulty gene that affects the brain and the nervous tissue. This disease is passed down through the generations and only affects those people who have got the faulty gene. The thing with Huntington's is that it doesn't just involve the person who is affected, it's a family disease. And it's so important for the whole family to understand that no one is to blame for getting this disease or passing on this condition. It is generally an adult-onset disorder, and children under the age of 18 are not really eligible for testing, excluding juvenile Huntington's, where the onset of symptoms may be before the age of 20. So just in general, Huntington's usually starts between the ages of 30 and 50, and the symptoms last for about 15 or 20 years and affect both the body and the mind. Unfortunately, there's no cure, and there's no easy answers to managing the symptoms, although there are some medications that are available to help alleviate some of the symptoms. So what we aim to do in genetic counselling is to empower people by understanding the condition and helping them understand what challenges they might face in the future. Just having a look, I'm not sure exactly how many people are affected with Huntington's in the country. Now, I don't know if we have that kind of data, but the average prevalence in different populations around the world is around about 10 to 17 people affected per 100,000. So also chromosomes and genes, just to remind you that Huntington's is generally caused by a single gene disorder. The gene's name is HTT and it sits on chromosome 4. This causes Huntington's disease type 1. There is a Huntington's disease like 2, which is caused by a different gene called JPH3 gene. Both of them are inherited in what we call an autosomal dominant manner, which means that for a parent who is affected, there is a 50% risk with every child of passing on that faulty gene. And this is what a typical autosomal dominant family tree may look like, where there are affected people, both men and women, from all generations that are affected. So HD, or the most common type of HD, is caused by a CAG repeat. So CAG referring to the nucleotides in the DNA string, in the HTT gene, which sits on chromosome 4. There's an HDL-like 1 condition caused by the PRNP gene, the HDL2, which I've mentioned already, which is a slightly different repeat, a triplet repeat, which is the CTG repeat. And then more recently, there's an HDL3, which is an autosomal recessive condition, and it's been linked to a certain area on chromosome 4. So just routinely, the testing that is offered for Huntington's disease in terms of making a diagnosis or pre-symptomatic testing, we look at the HTT gene and at the JPH3 gene. So this is how a repeat expansion works, where we have the string of DNA. I forgot, sorry, I'm trying to use my mouse to show you. But where we have a string of DNA, where we have these trinucleotide repeats of CAGs. And the CAG triplet nucleotide codes for a glutamine protein. And so what happens with having a whole string of CAG repeats next to each other is that we have a whole lot of glutamines in the protein together. And so what happens when we look at the genetic testing is that we have a look to see how many of the triplet repeats are present in each individual in each of the 8 genes. So anywhere between 10 and 26, we would consider having that number of CAG repeats as normal. If we have an intermediate range of CAG repeat numbers, namely between 27 and 35 repeats, this is what we call the intermediate range. It does mean that if there are a number of repeats in the intermediate range, that this person will not develop Huntington's disease in the future. However, we know that for a number of repeats in the intermediate range, this has the potential to increase through generations. So if you would look at the repeat number in the next generation or even 2 generations later, we may have had an increase in the number of repeats in that particular region. For someone who's got repeats in the 36 to 39 range, we call this reduced penetrance. This is a very tricky area in Huntington's disease counseling because we never know if someone who has a copy number within this region, whether they will develop Huntington's or whether they won't. And it is so variable, even within the same family with the same number of repeats, is that you can have different penetrance, meaning that some people will develop Huntington's, some may not, some may develop it at a much later age, and some may not develop it at all. However, the one thing that we do know is that for people who have the number of triplet repeats from 40 and above, is that at some stage during their life, they will develop Huntington's disease. So this is the effect of the protein, of the faulty protein, and how it works is that the number of repeats that codes for that glutamine, it will increase in terms of the number of glutamine amino acids that are present in the protein. And when you can see that the protein aggregate is a much different protein structure from the normal Huntington protein. And what happens is that because of the abnormal structure of this protein, is that they clump together and they affect the normal functioning of the nerve cells. And you can imagine that if this Huntington protein aggregates in certain areas, for example, in the brain, in the nervous tissue of the arms, the legs, wherever it might be, that it will then cause damage. So looking at the brain of an individual who's been affected by Huntington, you can see the damage that the abnormal protein has caused on the physical structure of the brain. So some of the symptoms of Huntington's, the symptoms are put into 3 general categories. The motor symptoms, I think, are the most easily identifiable, where people lose their balance, they fall easily, they may seem uncoordinated, or they may have difficult chorea movements. So chorea is the Greek word for dancing, and they have abnormal uncontrolled movements, often of the hands or of the feet, and that's where it's most noticeable. If we have a look at emotional or behavioral aspects of the condition, we may have issues such as anger, anxiety, apathy, and depression. And so you can understand that it really could be quite difficult to have someone who presents in a GP's room with anxiety and with depression and be able to know whether this is associated with a history of Huntington's disease in the family, or whether this is just caused by everyday kind of life, or that someone is at a predisposition for these conditions. And then if we have a look at the cognition, executive functioning often tends to be one of the final things that happens. Earlier on, attention and concentration are difficult, and then learning and memory skills can be quite affected as well. Communication becomes much more difficult later on as well, where it could be difficult to source words or understand concepts that you used to be able to know. And then one of the things that happens if we go back to the motor column is that later on in the condition as well is that the speech and the swallowing becomes very difficult. So there are a whole host of different symptoms that we know are associated with Huntington's. And just as with the triplet repeats, different people in the same family can present with different initial signs of Huntington's and progress in different ways from other people who are affected in the family. So we have divided up the genetic testing into diagnostic testing and into predictive testing. The diagnostic testing means that an individual currently has symptoms and they need to have been assessed by a neurologist or a psychiatrist. And there are best practice guidelines for when Huntington's disease should be tested from a genetics point of view. And empath and genetic counsellors around the country, we know, abide by the guidelines of Huntington's because it is such a tragic and difficult disease to diagnose, to manage, and to handle for families. If we have a look at predictive testing, this is when people who belong to a family where Huntington's disease occurs, is where people who don't currently have symptoms but are at an increased risk of developing Huntington's disease in later life. So there's an international predictive testing program, and we recommend that people who would like to find out if they're going to be affected by Huntington's in the future actually go through the process of this predictive testing program. So there are recommendations, there are guidelines, and we like to abide by these because we feel that this is the best way to support an individual, but also the best way to support a family in terms of entering into this predictive genetic testing process. It's important that the age of consent is adhered to, so we generally won't test someone under the age of 18. We obviously like to, it would be preferable to test people who are a little bit older, have made life decisions going forward, and have not let the prospect of Huntington's impact on those. So the predictive testing program involves a multidisciplinary team, which includes genetic counsellors, assessment by a neurologist, assessment by a psychiatrist to see if there are any initial clinical signs of Huntington's, and then a psychologist who has got experience in Huntington's or who will be able to look at several sort of tests and scales that they use in terms of coping skills and stress scales, and see how someone who doesn't currently have Huntington's disease would cope in the future with getting test results, whether they be positive or whether they be negative. Both of them can have such a dramatic impact on people. So that is what is recommended, and we like to adhere to that as much as possible. So just having a look at the genetic testing itself, I've cascaded these in terms of the top left is where we have 2 alleles or 2 HTT genes where the triplet repeats fall within the normal range. If we have a look at the middle diagram, it's where we have a repeat that is within the normal range, and then the allele on the second HTT gene is in what we call the premutation range. So that would be between 36 and 39 repeats. And then the last diagram on the right-hand side at the bottom shows where we have one allele that is within the normal range and then one allele that is greatly expanded. And you can see the difference between those 2 peaks, where the second one is within the affected range, meaning over the cutoff of 40. So the role of the genetic counsellor is to assess risks of Huntington's based on the family history, to discuss the cause, the inheritance, and the reasons for testing, and then looking at the different genetic testing options as to whether someone has been diagnosed with Huntington's in the family before and which is the gene that we should be looking at. We provide support and we explore the possible impact on lifestyle that getting a genetic result for Huntington's could have. We facilitate the testing process, and we also refer to the multidisciplinary group, and different places around the country have got different teams of people who consist of psychologists, neurologists, and psychiatrists. The support group, the Huntington support group, is phenomenal. They offer a great support to individuals who are taking care of people, other family members with Huntington's, or children that are in the family where there's a parent that is affected with Huntington's. And I know that we have a strong Huntington's group in Pretoria and a strong Huntington's group in Cape Town. But obviously, either of those are accessible. So lots of ethics surrounding genetic testing for Huntington's, and we need to be careful about testing children, about testing young people, and how general practitioners then approach the aspect of predictive testing for Huntington's. We do get quite a lot of requests for Huntington's predictive testing from GPs who may not be aware of the predictive testing process. So each case should be considered on the merits of the family, how the family functions, and the understanding of the people who want to enter into the predictive testing program. So here are some of the support groups, and the HDYOs, the Huntington's Disease Youth Organization, where there are people generally in their teens and their early 20s who support each other either through the process, considering the process, or have been through the process of predictive testing. And then I quickly wanted to touch on Alzheimer's disease, where there is such an overlap of symptoms in many ways between Alzheimer's and Huntington's. With Alzheimer's, however, there's no direct genetic test that will either definitely predict or diagnose an Alzheimer's disease. So Alzheimer's remains a clinical diagnosis. There is some correlation with the ApoE gene, where a particular variant of the ApoE gene may be associated with a predisposition, but this is still only an association and not an actual diagnosis. So Alzheimer's onset in the mid-50s. However, there can be an early onset of Alzheimer's, which may occur as early as mid-30s. And less than 10% of patients with Alzheimer's are diagnosed with early onset Alzheimer's. Alzheimer's disease is generally assessed by having a clinical neuropathological assessment, and it is characterized by slow progressive dementia. Neuroimaging is used a lot of the time in the diagnosis of Alzheimer's, and there are many differentials to Alzheimer's disease, which include depression, drug intoxication on some of the non-genetic ones, and then there might be other degenerative disorders such as dementia, such as Lewy body dementia, frontotemporal dementia, Parkinson's disease, and then CADASIL. CADASIL is one of those genetic conditions that can be assessed by genetic testing of the Notch3 gene. Sometimes within a family, there can be something called familial Alzheimer's, where 3 or more people within the family is affected with Alzheimer's. And this accounts for about 25% of people who are eventually diagnosed with Alzheimer's. However, 75% of people diagnosed with Alzheimer's have a non-familial, and it will be the only incidence of Alzheimer's in their family. So if we have a look at Alzheimer's disease from a genetics point of view, there are many susceptibility genes, and these have just had some association with causing Alzheimer's, but none of them at this stage are diagnostic. When we look at the early onset or the familial type of Alzheimer's, a certain portion can be attributed to pathogenic variants in APP, PSEN1 or PSEN2, but these are relatively rare, and so genetic testing for this is not routinely offered. So coming to Alzheimer's, Huntington's, and in fact any of the genetic conditions that we've been talking about through this whole series, is that family history is really key, and this is really the start of having a look at the family, having a look at the conditions that occur in the family, and looking at the inheritance patterns that occur. So this is just an autosomal recessive tree where we can see one incidence in the index patients or the index couple of consanguinity. This is a family tree that I've recently drawn up where there is a very large amount of consanguinity going on in the family, and many people affected with different genetic conditions, which I haven't actually put in this example of the family tree. but the little boy in that's coloured in the red circle there has got a genetic condition, and we're thinking that it's related to the same condition that was identified in another family member. So summarising, the family history can be quite complex. It took quite a long time to draw up this family tree and put the whole story together, and knowing how everybody was related to each other. So if we can just summarise what we have done over the past 4 weeks, we have started off by looking at planning a pregnancy and doing carrier testing. We spoke a little bit about doing some genetic analysis on a pregnancy and knowing what the risks were for having children affected with a genetic condition, or particularly with a chromosomal abnormality. Newborn screening we didn't really talk about so much, but we spoke about some of the pediatric conditions and how to diagnose some of those childhood genetic conditions that are so common. We then moved on to adult onset conditions, and particularly we spoke about the common conditions such as hemochromatosis, we spoke about hypercholesterolemia, and we also spoke about the role of pharmacogenetics and how this can help us in our adulthood. Today we've spoken about cancers, and we've spoken about psychiatric conditions and neuropsychiatric conditions which occur much later on in a person's life. So that brings us to the end of our talks for today. And if anyone has any questions, please put them into the chat box. But I think that we'll move on to our polls. And let's see if I can bring up the polls for us. So let me just click there so we can display the results at the end of the poll. So the first question is, going back to Julie's talk, what percentage of breast cancers can be associated with BRCA germline mutations? Okay, so there's a couple of people answering some questions. So the majority at the moment, looking at 88%, 90% of 5 to 10%, and some people answering 75%, and no one yet has answered 15 to 20%. And I think if everyone's finished answering for now, we will end it there. And so we've ended up with 70% of our audience thinking that 5 to 10% of breast cancers are associated with BRCA germline mutations, and 28%, close to 30%, thought around 75%. Julie, would you like to give us the answer?
Yes, thanks, Sarah. Yes, the majority of people are correct. 5 to 10% of our breast cancers can be associated with BRCA germline mutations.
Okay, so moving on to the next question. A person who inherits one pathogenic variant in the BRCA1 gene from a parent has or will get breast cancer. I hope that that poll has come up. So a couple of people have answered already. Okay, nothing was changing very much here. So from my side, I'm seeing that everybody who has responded to this question so far has responded false. 2 more seconds. Okay, and I think that we'll leave it with 100% of respondents answering that a person who inherits one pathogenic variant has or will get breast cancer. So is the answer of false correct, Julie?
Yes, the answer is correct. We said with a BRCA1 mutation or BRCA2 mutation, you've got an increased risk to be diagnosed with breast cancer.
Okay, so let's have a look at our next question. Which of the following may indicate a hereditary cancer risk? Triple negative breast cancer under the age of 60, male breast cancer in both breasts, breast and ovarian cancer in the family, or all of the above. So breast and ovarian cancer in the family is becoming quite popular. No one's answered about a triple negative breast cancer yet. Okay, let's give you another 3 seconds to respond. Okay, so if we finish off this poll, we can see that 95% have said all of the above. Julie?
And that is correct. All of the above can be associated with your inherited breast cancer. So well done.
All right, so let's have a look at the next question in the poll, which is to do with Huntington's chorea. And the inheritance pattern for Huntington's chorea is autosomal recessive, dominant, X-linked recessive, X-linked dominant, or mitochondrial inheritance. So remember that these are all of the inheritance patterns that we spoke about in our first session 4 weeks ago. And everyone who has answered has said autosomal dominant. So that's awesome, well done. Okay, our next poll question is symptoms of Huntington's chorea include, and there are a few different clinical symptoms that may be present. These include aggression, balance problems, difficulty with problem solving, and psychosis. All right, so everyone who's answered so far said all of the above. And I think that we will leave it at there. Okay, we've just reached 7 o'clock. So I would just like to conclude our session this week and in fact conclude our 4-week seminar series with thanking everybody who attended. I feel it's been helpful, it's been useful, it's provided some education, some knowledge, and hopefully you will have learned a lot from these 4 sessions that you've attended as well. And we'll hand over to Yanri just to conclude. Thank you, Yanri.
Thank you, Sarah. Thank you, Sarah and Julie. It was a very interesting session. And I would like to thank everyone for attending this session, and especially to all of you who have attended the whole series. I really do hope that it's been very educational. And please note that we are in the process of issuing the CPD certificates. If you completed the survey for CPD points upon registration, you will receive a CPD certificate for all the sessions that you have attended. Thank you so much. Enjoy your evening, and we hope to see all of you soon again.